Good morning, my dear students. I have taken the topic of adverse effects of penicillin for today's discussion. Penicillin causes all four types of hypersensitivity reaction, but the most important one or the dangerous one is anaphylactic shock, which is also known as type 1 hypersensitivity reaction. Commonly, the hazards which can be manifested with penicillin is allergic reaction. This includes itching, rashes, fever, angioedema. And rarely, 1 in 10,000, there is a chance of anaphylactic shock, which can be fatal. About 1 in 50,000 or 1 in 1 lakh treatment courses required. The risk of allergic reactions is around 5 to 10% with benzathine penicillin, 2 to 5% with procaine penicillin, and less than 3% following benzyl penicillin. The mortality is severe reactions has been assessed as 9 to 13% overall. As a generalization, the incidence of these reactions is considerably greater when benzyl penicillin is used either topically or in an aerosol form. Later on, we'll show you in a slide that it is probably the least when taken via oral route. However, fatalities have occurred following ingestion. Some individuals are so sensitive that mere handling of penicillin tablet or even a skin test dose may precipitate immediate severe reaction. Further severe reactions have been recorded following first dose of penicillin in persons who had never received the drug before. This has happened because many of us are exposed and slightly sensitized to various common airborne molds that readily grows on an elaborate penicillin and penicillin-like substances in foodstuffs such as bread, fruit, oil, with or without decay. Now, penicillin sensitization can also occur from the presence of the drug in the environment of patients using penicillin aerosols and by ingesting milk containing penicillin. Other kinds of adverse drug reactions which can be seen with penicillins are maculopapular rash, urticarial rash, fever. This is probably a case of 10. Toxic epidermal necrosis, maybe Stevens-Johnson syndrome, maybe an overlap of Stevens-Johnson syndrome and toxic epidermal necrolysis, anaphylaxis, which I have mentioned before, exfoliative dermatitis. So all these reactions are not pretty common, rather they can be seen with penicillin-like drugs. Now, why it's happening? It can occur with any dosage form, as I said, but orally probably it is seen in the least number of cases, and most likely it is seen with local application. Now, it's a metabolite present in the penicillin. While discussing the structure of penicillin, we have discussed a term penicilloic acid. Either alone or linked to a plasma protein is probably responsible for this allergic reaction. So, it is the penicilloic acid, which is basically a metabolite of penicillin, either alone itself or linked to a plasma protein, is probably responsible for these kind of allergic reactions. And a person known to be allergic to one penicillin will also be allergic to usually other penicillins. Partial cross allergy is seen between penicillins and cephalosporins. Cephalosporins and the monobactam, however, carry much less risk. The anaphylactic reactions involve specific Ig antibodies which can be detected in the plasma of susceptible individuals. You may have seen that the patient is suffering from serum sickness due to penicillin, which is usually IgG mediated, and is characterized by mild fever, rash, leukopenia, as associated with arthralgia, purpura, and lymphadenopathy. Sometimes you will also see the mental changes, myocarditis, edema, and involvement of kidney, and which is characterized by albuminuria. Whereas in anaphylactic episodes, two things are pretty common. One is hypotension and the other one is bronchoconstriction. So dyspnea is a characteristic feature of anaphylactic episodes or breathlessness in layman's term, which can be characterized or characterizing feature of anaphylactic reactions. It may be associated with abdominal pain, nausea, vomiting, weakness, purpura, and even sudden death. So you must be very, very careful about using penicillin-like preparations or penicillin itself with the benzyl penicillin, and always keep the life-saving drugs in your hand. In case of any reaction, you always start treating it immediately. So, as I said before, the cross allergy between various forms of penicillin is happening because the structures are common. They are all belonging to beta-lactam group of antibiotics, and if they are coming from the common source, then probably the chance of this cross allergy is more. It is existing between penicillins and cephalosporins, which is of particular concern in case of angioedema or anaphylactic shock, but we have seen that in case of cephalosporins, the chance of hypersensitivity reaction is lesser in comparison to penicillin. And in case of carbapenem and monobactams, it is even lesser. When a person is presented with a history of allergy, it is not clear and it is necessary to prescribe penicillin to this patient. Like in case of syphilis, you have to prescribe a drug like benzathine penicillin. The presence of IgE antibodies in serum is a useful indicator of reactions mediated by these antibodies, and mostly it is seen with type 1 hypersensitivity reaction. Additionally, an intradermal test, which is called a skin test for allergy, may be performed, and desensitization is probably the way by which these kind of things can be solved permanently. Now, how you will perform a skin test? One method of skin testing is to scratch the skin through a drop of solution containing 10,000 units of benzyl penicillin per milliliter. If a central wheal due to local edema, not diffuse edema, it is the local edema, occurs after 15 minutes, you can consider it as a positive reaction. So the characteristic features are central wheal due to local edema, and it occurs after 15 minutes. A positive skin reaction is a relatively reliable indicator of potentially serious penicillin allergy. Unfortunately, fatal anaphylactic reactions can occur, though rarely, even in patients with negative skin response. And in that case, you are helpless. You can't do anything because you have already performed a test and which is proved to be negative for the patient. And that's the reason why you have prescribed penicillin to that person. But in our everyday clinical practice, it is not possible to perform this kind of test, and only in a hospital setup, probably we are doing it, especially in case of injectable preparations. In case of oral preparations, and when you are prescribing penicillin in form of amoxicillin, ampicillin, or even the other oral forms, mostly these kind of tests were not performed by the general physicians. So that is one of the limitations of prescribing a drug like penicillin in a developing country. Skin test also involves the administration of 0.05 milliliter of penicilloyl polylysine intradermally and subsequent observation of the inflammatory response. This test is often combined with benzyl penicillin scratch test. Combination of these two tests will predict virtually all reactions to all the types of penicillin Scratch test should precede the intradermal test to avoid any dangerous reactions following the latter. Such elaborate testing, however, as I said, may not be feasible in clinical practice, especially in a country like India or in West Bengal. If a person with positive skin test has to be administered penicillin for a life-threatening infection, penicillin desensitization should be carried out under the coverage of glucocorticoid and antihistaminics in a closely monitored setting. And you will also keep the life-saving drug adrenaline in your hand. The dose of adrenaline is 0.3 to 0.5 ml at a strength of 1:1000 dilution by subcutaneous or intramuscular route. Diarrhea sometimes happens due to alteration in normal intestinal flora, which may progress to Clostridium difficile associated diarrhea. And this is also called superinfection, which is not a characteristic feature of penicillin like drug. Rather, it is seen mostly with the other drugs like tetracycline or clindamycin. Pain and sterile inflammatory reaction at the site of intramuscular injection is quite uncommon, but if you see these kind of things, you should predict it as a penicillin induced some kind of reaction. Neutropenia is a risk if beta-lactam antibiotics are used in high dose and usually for a period of greater than 10 days. Rarely we see that penicillin is responsible for causing anemia and sometimes hemolytic or thrombocytopenia or even interstitial nephritis. Penicillin are presented as their sodium and potassium salt, especially with carbanicillin. It's containing a huge amount of sodium. So in patients suffering from heart failure, these kind of drug like carbanicillin should be avoided. Otherwise, this excessive sodium load will precipitate further heart failure. Extremely high levels of plasma penicillin concentration may cause convulsion, and that can be also seen as a case of seizure. So that is tackled with benzodiazepine like drugs, but it has happened almost doubling, or even if you prescribe penicillin more than the usual doses. Hemostasis and platelet aggregation with penicillin G, carbanicillin and piperacillin is very rarely observed. Amoxicillin and clavulanic acid combination, the penicillin is resistance penicillin in high doses for prolonged periods in elderly may cause liver toxicity. Penicillin may also cause Jarisch-Herxheimer reaction. It should be written as Jarisch, and Herxheimer is Herxheimer, and it is a rare reaction reported in patients with syphilis treated with penicillin. This Jarisch-Herxheimer reaction consists of an initial exacerbation of lesions at any stage of syphilis following the first dose of a quick-acting drug like penicillin. This will kill the organism responsible for causing syphilis. Any reactions that occur after subsequent injection of penicillin is unlikely to be due to Herxheimer phenomenon. The phenomenon is due to a rapid destruction of a large number of spirochetes with release of endotoxin. It occurs in many cases of early syphilis and it leads to an aggravation of the mucocutaneous lesions and a mild systemic illness, which consists of malaise, tachycardia, and fever. Usually on systemic examination, you will see the lymph nodes are enlarged and tender. It lasts for 2 to 6 hours, but it is harmless. And this is not an indication to stop penicillin. Whether in case of anaphylactic shock, you have to stop penicillin, otherwise the patient will die. The patient should, however, be forewarned about it, otherwise he might feel that wrong treatment was administered and you know the consequences. The treatment with penicillin must be continued. A sharp febrile reaction occurring within 24 hours of the use of penicillin in gonorrhea suggests the possibility of concurrent syphilis, as Jarisch Sexamer reaction is known to occur even in the incubation period of syphilis. This Jarisch Sexamer reaction is not only a characteristic reaction happening with penicillin, it can also be seen with tetracycline like drugs. Fatalities are very uncommon with this. Only paracetamol is probably going to take care of the event. If it is not sufficient, then you may have to take some other measures to control the situation. Intramuscular aqueous procaine penicillin injection sometimes produces acute non-allergic reaction, which could have been serious. It is characterized by transient palpation, hypertension, twitching, auditory and visual disturbances. In addition, the psychiatric symptoms like fear of imminent death and acute depersonalization may occur. So all these are the characteristic feature of adverse drug reactions happening with penicillin. In case of adverse drug reactions, especially the anaphylactic shock, if it is happened with penicillin, not all, or even any kind of reactions, if it is happened with penicillin, especially the skin reactions, you can prescribe corticosteroid, and corticosteroids are quite effective in these conditions, especially in different types of skin reactions. Usually 0.5 to 1 milligram per kg of body weight prednisolone is prescribed to tackle this situation. And antihistaminics, they do not decrease the incidence of penicillin anaphylaxis, but they are valuable in controlling common minor allergic reactions. So keep it in your mind. If you see simple harmless reactions and you are suspecting it due to penicillin, you can prescribe antihistaminics. And if you see that it is not happening due to this kind of reactions are probably due to penicillin, but these are not that simple, then you shouldn't go for this kind of antihistaminic treatment. Even in patients in whom the skin test is negative, most physicians administer a test dose of 1000 to 2000 units of penicillin and proceed to higher doses if no reaction occurs. So this is little bit about penicillin, and as I told you before that penicilloic acid, keep it in your mind that penicilloic acid, which is a metabolite of penicillin, either alone or linked to a plasma protein, is responsible for most of these allergic reactions. And partial cross allergy is seen between penicillin and cephalosporins, but it is less common with monobactam and carbapenem. So out of all the groups, in case of beta-lactam antibiotics, the chance of reactions are higher in case of penicillin group of drugs. And that's the reason why the adverse drug reaction of penicillin is very important for your study purpose. Adverse drug reaction with cephalosporins are well tolerated it is usually characterized by local reactions, which is happening mostly due to intramuscular injections, and they are extremely painful. And IV injections sometimes cause thrombophlebitis. Allergic reactions like penicillin may occur with cephalosporin group of drugs. The drug fever is not very uncommon with these groups, as it has 4 groups. It may lead to different types of fever-like episodes. Superinfection, just like penicillin, is rarely seen with cephalosporins, whereas the nephrotoxicity may be happen due to large dose and is probably dose related, potentially reversible on drug withdrawal. So that is one of the advantageous side of prescribing cephalosporin. It is only enhanced by loop diuretics such as furosemide. CNS toxicity like cerebral irritation, hallucination, nystagmus, and ultimately seizure may occur while intrathecal drug administration. The hematological toxicity can also be seen with cephalosporin-like drugs. A parenteral vitamin K therapy will correct the abnormality and is recommended prophylactically when cefoperazone or cefotitan or cefamendal are used for prolonged periods. A false positive Coombs test may occur in as many as 60% of the patients on cephalothin therapy. Cefoperazone and cefamendal may cause disulfide-like episodes, which also can be seen with metronidazole when the person is also taking ethyl alcohol at the same time. Cefotitan is also responsible for causing similar type of reactions. In patients with a history of severe allergy to penicillin, as I mentioned before, that cross reaction to cephalosporin is about 0.1%. So the chance of cross reaction is there, but the chance of cross reaction with the monobactums and the carbapenems are minimal. So that's all for today's discussion, and with this presentation I am closing the topic beta-lactam for this year. Thank you for your kind attention.